Now, what did you see?
Scrotal swelling.
Left side and right.
Okay. For you people, you saw it? You learnt transillumination?
Yes.
You also?
Yes.
And you taught them about what is scrotal, what is...
Inguinal scrotal versus inguinal and the side extent.
So the bottom line is, a scrotal swelling is scrotal because you can get above the swelling.
About the swelling.
Always examine all inguinal scrotal swellings in standing position, because otherwise you would not know whether you can get above. You can't get above something which is lying supine. Secondly, when your patient is standing, I'm just making it clear to you, always examine inguinal scrotal swellings in standing position. It can be a tumor also. Right? Why should you examine it in standing position? Because small hernias may show up. In addition to the inguinal, you may have femoral, ventral hernias. All hernias show up better. And a very small hernia may show up only in standing position, so you may not miss it. And then secondly, you can feel the cord separately because your cord is above that. And in the inguinal swelling, you can feel the testis separately. While in a scrotal swelling, you can't feel the testis separately. Right?
Yes.
Because it is arising from there. Except one scrotal swelling where you can feel the testis separately.
Sinuses of
Testicular mass, how will you feel the testis separately?
cyst of Morgan. Cyst of Morgan.
So the hernia which is
एक मिनट रुक जा. Encysted hydrocele of the cord. It's a scrotal swelling while the testis is felt separately. Some people even say epididymal cyst, but that is difficult to differentiate. It's the only swelling where you can feel the testis separately. Otherwise, scrotal swelling, testis is usually not felt separately. Inguinal swelling, you can feel it separately. Then, of course, the cuff impulse, etc. How will you know this scrotal swelling is not a benign swelling? It's a malignant swelling. What are the features?
So we'll have points in history and points in examination. Points in history, sir, patient may have symptoms of advanced disease like weight loss and symptoms of metastasis like lungs and liver involvement, sir. Points in examination, sir, patient may have...
No, history. Talk about the swelling first.
So swelling also, sir, the patient will have a
No,
rapid
I'm
history.
repeating it for you all, and for her too. The whole concept of oncology is based on T, N, and M.
History for T.
Take history of T, history of N, history of M. Examine for T, for N, for M. Investigate for T, for N, for M. Treat for T, for N, for M. Khatam. So history of T can be a swelling was painless, rapidly growing, and loss of testicular sensation. Testicular sensation, the patient has to report. It's a history, not examination. People do this mistake. You're not supposed to do it because it will be painful to the patient. Sickening sensation, illness can happen. But patient will give you the feeling that that sensation is different from the other side. And then there can be metastatic history which you mentioned. On examination to be a hard swelling. Hard.
Heart swelling.
The cord may be thickened, but it's a scrotal swelling. Skin or may or may not be involved. Right? Then you can also, when you're saying hard, don't need to say transillumination. Sometimes there is an area of necrosis. What is a variegated swelling? Sumedha, I must have taught you in undergraduate times. How is it different from variable consistency?
Variegated swelling is diffuse.
What is the difference between variegated and variable?
So variegated will have different consistencies, hard, firm and cystic, whereas variable
More than one.
more than one.
So, variable means more than one type of consistency. It can be any two. But if there are three, all three, soft, firm and hard, we call it variegated because it's more suggestive of cancer. How? When the cancer is evolving, from soft it becomes firm and hard. When it is dissolving, necrosis happens, it can be soft and hard. So it will have soft, firm and hard, all three. The same would show as heteroechoic on ultrasound. Hetero. So There may be some areas of necrosis which can show fluctuation. But don't percussive scrotal swelling, which I taught you the other day. Don't do that. Hernias, it's all nonsense. Because you can't percussive test for fluctuation or translumination unless the swelling is fixed. So don't do these tests in swelling that are not fixed. And then you may have lymph node involvement. Which are the lymph nodes that drain testis?
So inguinal lymph nodes.
Okay. Periodic nodes. Pre and periodic, not the inguinal. Inguinal drain the scrotum. So if the inguinal are palpable, then you're probably dealing with the involvement of the skin. The skin is involved.
It becomes M1 because inguinal is not.
And that is not a regional disease. They are not the regional lymph nodes. So any time a malignancy drains into a non-regional lymph node, it becomes a metastatic disease. Clear?
Yes.
So on examination, find epigastric mass usually. At what level is the bifurcation of aorta?
L3,
Clearly?
L3, L4.
L3, L4. So it corresponds to what? Umbilicus. So that's why when putting a pneumo needle sometimes, that's what precaution you take. And you don't go vertically into the bifurcation, that's where it bifurcates. So you can feel the lymph nodes in the hypogastrium or in the around umbilical region. Or these things. There can even be a Burkhouse node palpable due to the involvement of the thoracic duct and where it opens up into the Burkhouse node. So this is how you would be differentiating it from a benign swelling clinically. Clinically, I'm saying. Any other doubt? How do you confirm the diagnosis? You don't do FNAC. Why don't we do FNAC in a scrotal, in a testicular tumor? Any guess?
So we cannot fix the
FNAC.
Sir, a very vague assumption कि sir testes are actually protected by testes and blood barrier. So if we breach, then sir, immune cells can invade.
I just not told you. If you go through the scrotal skin, you will upstage the disease because scrotum is draining into inguinal lymph nodes. That is making it a advanced disease.
Involvement of scrotum makes it T4 and inguinal lymph node makes it M1.
So when you go through the skin, the scrotum gets involved, it becomes a T4 disease. And that drains into inguinal lymph nodes. If inguinal lymph nodes are involved, then it becomes a M1
Metastatic
disease. So you don't put in a needle, you do an ultrasound. And but don't be afraid of answering. Don't answer in a hurry, but don't be afraid of answering. There are no mistakes. There are only lessons. But if you repeat a mistake, that's a decision. But do make your mistakes. And let me also tell you, life is too short to learn only from your own mistakes. Learn from others' mistakes also. So that's what all of you do. You're waiting for others to commit mistakes and learn. Make your own mistakes also because you remember them.